Good morning, friends. I'm Dr. Shabeer. I'm working in ICRA Hospital Kozhikode as a consultant neonatologist. Myself and Dr. Sridhar from Vellu will be discussing on basic concepts of neonatal sepsis in the next couple of days. Neonatal sepsis is a major public health burden. India has the highest under 5 mortality, and 60% of these deaths are happening in neonatal period. Of these, 12% of deaths can be directly attributed to neonatal sepsis. And apart from that, many of the mortalities related to premature birth can be associated with neonatal sepsis. So this figure might be even higher than this. If you consider infections in pregnancy and perinatal period together, the infections can be attributed in at least 10 to 25% of stillbirths, and this data are from Western literature, and the figures may be even higher in developing countries. And it has got a huge economic burden, and the neurodevelopmental disability which is associated with the sepsis survivors is huge. 18% of babies had a moderate degree of moderate to severe neurodevelopmental impairment following sepsis. There is no clear definition or no clear consensus on definition of sepsis. It is variably defined in various literature, and this is one of the definitions. It's a systemic condition of bacterial or sometimes viral or fungal origin associated with hemodynamic changes and other clinical manifestations. It results in substantial morbidity and mortality. The positive blood culture from a normally sterile site such as blood is a gold standard for defining sepsis, but isolation of a pathogen is not always equated with sepsis. Sometimes commensal organisms can be cultured from the blood. So in that situation, it may or may not be a true infection. So you have to be very clear on whether that has to be taken as just a contaminant or a true infection. You have to consider other clinical and other laboratory parameters to reach a conclusion. Similarly, inability to identify a pathogen does not rule out infection all the time. Some bacteria may not be grown in culture, and as you know, the viruses are not generally seen. It's not seen in our routine blood cultures, and many times even some bacteria which has got a fastidious growth requirements might not be really grown in culture. So coming to the classification of sepsis, it is broadly classified into early onset sepsis and late onset sepsis. Early onset sepsis has got a early presentation. Usually the clinical manifestations will appear within the first 48 to 72 hours of birth, and this demarcation of early and late or late onset sepsis is also a bit arbitrary. In various literatures and various clinicians define it differently. Some in literature it might be given as within 7 days it can be considered as early onset. More than 7 days can be considered as late onset. So both the definitions are acceptable, but in general the infections which appear or the manifestations which appear before 72 hours is considered as early onset, and most of the time it is the infection which is acquired from the mother, that is vertically transmitted from mother to the infant. It can be acquired before or at the time of delivery. Late onset sepsis, so the manifestations often appear after 40 to 72 hours of life, and it can be up to 28 days. And in certain situations, especially like in group B streptococcal infections, this period can be as long as 3 months. That is called the very late onset sepsis. And most of the time, the organisms responsible for late onset sepsis are acquired from hospital environment or community, and sometimes it can be a vertically acquired organism which is just getting colonized in the first few days, and the invasion might happen after the conventional early onset period. So it need not be hospital acquired all the time. So in this this thing, it is defined as first 6 days and more than 7 days up to 90 days as late onset. And most of the time, the early onset sepsis, you may find complications of pregnancy or delivery, which can be considered as a risk factor for sepsis, and it may or may not be there for late onset sepsis. So source of organism is mostly from maternal genital tract in early onset. In late onset, it could be postnatal environment or maternal genital tract. The usual clinical presentation in early onset sepsis is fulminant, and it's almost always a multi-system disease, and pneumonia is a common finding in early onset sepsis. In coming to late onset, the progression may be slowly progressive, or it can be fulminant at times depending upon the underlying virulence of the bacteria and other host and infant factors. Sometimes the infection may be focal, and meningitis is a common accompaniment of late onset sepsis compared to early onset sepsis. And the mortality is almost comparable. 3 to 50% mortality is reported in early onset sepsis, and 2 to 40% mortality. That depending upon the setting, the mortality can vary. The organisms causing early onset sepsis include E. coli, Klebsiella, Staphylococcus aureus, group B Streptococcus, and Enterococcus. And the pattern of or the distribution of these early onset sepsis organisms is almost universal in all the countries, with some notable exception like Staphylococcus aureus, that is being normally described as a causative agent for late onset sepsis in Western literature. But in Indian literature, you can find a lot of Staphylococcus aureus presenting as early onset sepsis. Similarly, the group B Streptococcus is the most common pathogen which is causing early onset sepsis in many of the Western countries, but which is relatively uncommon in Indian setting. The organisms causing late onset sepsis is almost similar: the Klebsiella, Staphylococcus aureus, coagulase negative Staph aureus, and in addition to that, certain other enterobacteria like Enterobacter, Pseudomonas are common causes of late onset sepsis, and the Candida is that is a fungus, is basically is yeast, is commonly cause late onset sepsis, especially in extremely low birth weight babies and those who have indwelling catheters and those who have undergone abdominal surgeries, etc. And the prolonged empiric antibiotic therapy is also considered as a cause, as a risk factor for Candida sepsis in NICU. And other pathogens like Serratia and Acinetobacter is commonly acquired as a hospital-acquired infection and late onset neonatal sepsis. And as I said earlier, the group B Streptococcus can sometimes present lately. The common risk factors for early onset sepsis include spontaneous onset of preterm labor, preterm premature rupture of membranes, prolonged rupture of membranes, that is defined variably as more than 18 hours or more than 24 hours, maternal fever, that is more than 39 degrees Celsius, or two readings between 38 to 38.9 degrees Celsius, intraamniotic infection, otherwise called as chorioamnionitis. That is a clinical syndrome characterized by maternal fever with other features like foul smelling, vaginal discharge, lower abdominal tenderness, signs of fetal distress like fetal tachycardia, etc. Multiple vaginal examinations, more than 3 examinations after rupture of membrane is considered as a risk factor for sepsis. And maternal colonization with GBS in situations where you routinely screen the mother for GBS. If mother is found to be GBS positive, that should be considered as a risk factor for sepsis. And a history of previous baby with group B streptococcal infection can be taken as a risk factor for sepsis in the present pregnancy. So this is a study, systematic review and meta-analysis on risk factors of neonatal sepsis in India, in which you can find that the male gender, the outborn admission status, and need for artificial ventilation, low birth weight, are the major risk factor for neonatal risk factor for sepsis, the neonatal factors. And maternal factors include the delivery before term, that is before 37 weeks, and premature rupture of membrane. Other factors are not statistically significant. This is a study which is published from CMC Vellore, in which the perinatal risk factors for early onset GBS sepsis was studied. That is compared before and after the intrapartum antibiotic prophylaxis. Until 2003, the intrapartum antibiotic prophylaxis was not instituted. And when they compared the risk factors, the prematurity, prolonged rupture of membrane, and preterm onset of preterm rupture of membranes were not remained statistically significant in the post IAP era. The odds for peripartum fever, more than 3 vaginal examinations, and meconistein amniotic fluid are showing an association. The risk factors for late onset sepsis include the prematurity, some anatomical defects like urinary tract anomalies, gastrointestinal anomalies, gastrointestinal surgeries, perinatal nutrition, especially when it is prolonged TPN, mechanical ventilation, especially when it is prolonged, central lines, especially when the central line care or aseptic precaution is not strictly followed, use of gastric acid suppressions using H2 blockers and post-proton pump inhibitors, poor infection control practices, duration and prolonged duration and use of high-end broad-spectrum antibiotics, and whenever the environment is colonized with the virulent organisms. Coming to individual pathogens, the group B streptococcus is considered as a major pathogen in early onset sepsis, especially in the West, which is less common in India. It is otherwise called Streptococcus agalactiae. There are different serotypes, and the virulence is variable depending upon the serotype. It's often a commensal in lower GI tract and a genital tract in women. It can result in both EOS as well as late onset sepsis, even though the early onset sepsis is more common and classically described. Early onset sepsis presents as a multisystem illness with rapid onset, typically during the first day or two of life, and is frequently characterized by severe respiratory distress. The mortality rate is around 8%. The late onset infection is more insidious than early onset infection and often associated with meningitis and central apnea. Less often, it presents as a localized disease like osteomyelitis cellulitis in a later neonatal period. Escherichia coli is another common cause of both early onset sepsis and late onset sepsis. It's also a commensal of maternal birth canal. One particular capsular antigen, that is K1 antigen, confers a unique property to cause meningitis in E. coli. So those E. coli which has got this particular antigen will be having more virulence, causing neonatal meningitis. Infants who are born premature or very low birth weight are at highest risk of acquiring Escherichia coli sepsis. It is often associated with intrapartum fever and preterm premature rupture of membrane. Klebsiella is considered as the most common pathogen causing neonatal sepsis in the recent times in India. It's occur as a nosocomial pathogen. It can result in both early onset sepsis and late onset sepsis. The risk factors are similar, like preterm prematurity, very low birth weight, prolonged rupture of membranes, and cesarean section or instrumental delivery. The reservoir of transmission is mostly the hands of healthcare workers and GI tract of other hospitalized infants. The disease is often complicated by cholestasis, liver abscess, and persistent thrombocytopenia. Staphylococcus aureus and coagulase negative staphylococcus are considered as important pathogens for neonatal sepsis. Staph-Aureus is mostly hospital acquired, and it is classically described as a pathogen for late onset sepsis with a high mortality. In India, you can see a lot of early onset sepsis with Staphylococcus aureus. Coagulase negative sepsis include more than 30 different species, and Staph epidermidis is the dominant species of CONS. And normally it's a skin commensal, but it can result in infection in at-risk babies, that is especially for premature babies, those who have associated intravascular catheters, and those who receive parenteral nutrition with a lipid emulsion. Listeria Monocytogenes is another pathogen which is classically described causing early onset neonatal sepsis. It's acquired as a foodborne infection in mother. In healthy adults, it is often and results in a subclinical illness. But during pregnancy, Listeria can result in complications. It can result in fetal loss, and it can result in chorioamnionitis. The affected fetus often pass meconium in utero, and that's a clue to suspect Listeria monocytogenes, especially when a preterm baby is having meconium stain laca. You should think of a possibility of Listeria monocytogenes. It is often described as a common pathogen in Western world, but it is less often reported from the Indian literature. The transmission of hematogenous is hematogenous transmission, and the disease is often having a meningitis and has got a high mortality. Enterobacter is one of the common nosocomial pathogen which is being reported in the recent literature. There is a high frequency of multi-drug resistance among isolates, which is attributed to be due to the routine extended spectrum cephalosporin use. The reservoirs are similar, the GI tract of hospitalized infants, hands of healthcare personnel. It can be acquired as a contamination of infant formula or contamination of total parenteral nutrition. Other devices like bladder catheterization device, contaminated saline, all this can lead to Enterobacter sepsis. Citrobacter is another gram-negative bacilli that is an occasional inhabitant of the GI tract. Citrobacter's species are responsible for sporadic and epidemic clusters of neonatal sepsis and meningitis. Of these, Citrobacter quasar is particularly notorious for causing brain abscess. It results in cerebral vasculitis and that dead tissue can result in multiplication of bacteria and that can result in severe brain abscess. Most of the infants who survived had some degree of mental retardation. Serratia marcescens is another pathogen which is being reported as a cause of neonatal sepsis in the recent literature. It's a member of Enterobacteriaceae. It's mostly occur as a hospital-acquired infection. It's notorious to cause meningitis and brain abscess with often poor neurologic outcome. Pseudomonas is a well-known nosocomial pathogen. It often results in late onset sepsis. The sources are similar contaminated equipment, especially the aqueous solutions can have a good source of infection when it is contaminated with Pseudomonas aeruginosa. Occasionally, it can be transmitted from the hands of healthcare workers. And most of the time, it results in a fulminant sepsis with high mortality. It's reported as high as 50% mortality in pseudomonal sepsis. Sometimes the bacterial growth may not be significant. What are the situations? When your culture gives a positive result after 72 hours, you should think the possibility of a contaminant. Most of the true infections will show a growth by 48 hours, especially in the bacterial system of culture. And when you have polymicrobial cultures, sometimes it may be a contaminant, but studies shows greater mortality in polymicrobial sepsis. So it can be true polymicrobial sepsis also. So both are possible. So you should be very cautious when you interpret the results. You have to consider other laboratory markers of sepsis and the clinical picture of the baby, and then only you should take a decision whether to take this polymicrobial culture as truly positive or just a contaminant. In general, the dictum is polymicrobial culture including group B streptococcus or GNBs or Candida should be treated. When there is an underlying GA pathology, similarly, if you get a polymicrobial culture, that should be taken as serious. When you get a pure growth of skin commensals like CONS, diphtheroids, micrococci, alpha streptococci, anaerobic spore formers, this kind of bacterial growth is most likely will be just a contaminant. A baby doesn't have a strong clinical suspicion of sepsis. This growth can be ignored, especially when with CONS, which is a common commensal organs which is grown in culture, and sometimes it can result in sepsis also, the true sepsis. So if baby has got symptoms and there is a central line in situ, if you get two cultures which is showing a growth of CONS, it should be taken as significant. Coming to the clinical features, sometimes the fetal distress can be the earliest indication of a infection. Sepsis is often associated with a low Apgar score, especially when early onset sepsis. That means the process is happening in utero. That is, it might be happening as a hematogenous spread, or it can be an ascending infection in prolonged deliveries. The early signs of sepsis are often subtle and non-specific, like the poor feeding, diminished activity, or just not looking well may be the earliest features of sepsis. So as the disease advances, you may get more prominent findings like respiratory distress, apnea, lethargy, fever, hypothermia, jaundice, vomiting, diarrhea, skin manifestations such as petechiae, abscess, and scleroderma. The scleroderma is often considered as a late marker, and the prognosis of such babies might not be good also. Late onset sepsis can be more insidious at times. Baby might have symptoms like increasing apnea or bradycardia episodes, increasing oxygen requirement from the previous levels, feeding intolerance, abdominal distension, lethargy and hypotonia, temperature instability, unexplained metabolic acidosis or hypoglycemia. Term babies are more likely to have fever during a sepsis episode than preterm babies, and whereas preterm babies more frequently present with hypothermia than hypothermia. The signs of respiratory distress such as tachypnea, grunting, flaring of LNAC, intercostal retractions, rails, and decreased breath sounds can be appreciated. And apnea is often seen in fulminant sepsis. And other features of cardiovascular instability such as tachycardia, arrhythmias, and poor perfusion can often be seen in the sepsis. Jaundice is another feature which is very non-specific in neonate, but at times it may be a single feature of sepsis, and it is characteristically seen in urinary tract infections. So whenever you have an unexplained persistent jaundice, you should think of possibility of a urinary tract infection in such neonates. And most of the time, once you start appropriate treatment, the jaundice will improve. The gastrointestinal signs of sepsis include poor feeding, regurgitation or vomiting, large gastric residuals, diarrhea, and abdominal distension. The skin lesions which can be commonly seen with sepsis include cellulitis, abscess, petechiae, purpuric skin lesions, scleroderma, and you may get erythema multiforme and ecthyma in rare situations. Neurological signs of sepsis, especially those with meningitis, include increasing irritability, alteration in consciousness, poor tone, tremors, lip smacking, twitching of facial muscles, or frank seizures. The focal signs, including hemiparesis and cranial nerve deficits, must be looked for. And if there is a increase in intracranial pressure, you may find a bulging AF, which is commonly seen in meningitis or brain abscess. And sometimes you may find fluid and electrolyte disturbances as a complication of CNS infection due to SIADH, that is syndrome of inappropriate ADH secretion, or diabetes insipidus. Clinical manifestation of EOS and LOS are almost similar. Fever is more common in late onset sepsis, and meningitis is more common in late onset sepsis, and the unexplained fetal distress or asphyxia may be a clue for early onset sepsis. Thank you. We'll be continuing with the evaluation of sepsis tomorrow. Thank you.